Okay, good morning, everybody. It looks like it's 10 o'clock Central right on the dot, so we will go ahead and get started. Welcome to our June 2025 WPS Medicare Audit Provider Webinar. Hope everybody is having a great start to the summer. For this webinar, we have a variety of topics we are going to be covering. And before we get to that agenda, I just wanted to go through a few housekeeping items, just as a reminder for those of you that have not attended the webinars before. I will be sending out an email to any attendees, and actually I'll include anybody on the webinar list in general with a link to the YouTube recording, a copy of the PowerPoints, and anybody that did attend, anybody that's on the roster for either of the two sessions will get an attendance certificate and of course a copy of the agenda, which if you've already probably received a copy of the agenda, unless you're just now attending, maybe somebody forwarded that to you. So you'll get a copy of all of that. Now, for anybody that's not associated with a Mac, we have a survey that we'd certainly appreciate if you could take a chance to take a minute or two to fill out. And I've actually copied that right now. I posted that to the chat area, and I'll do the same thing toward the end of the session as well. But you can click on that and take that survey. And again, that is not for Mac staff. That's for anybody else, providers, home offices, consultants. Anybody else can take that, but anybody from WPS or any other Mac cannot take that. So just as a reminder there. And here's also a link to the survey. We have the QR codes if you want to scan those. That's another way to do that. They're on the actual PowerPoint that you may have already received. So now to the agenda. So, for the first quarter of the year, every webinar that we have, we always focus on S10. Now, this is obviously not the first one, but for each of the other webinars, we generally include that as just a quick agenda item at the beginning, just any new issues that have popped up. We do have a couple of reminders I wanted to put in there. So I have S10 uncompensated care audits, and then dish projects. We have a couple of just reminders there as well, updates on things that have been completed, new projects that are in the works right now. So we'll talk about that. GME, IME, FTE add-ons and caps, two different topics there really. We haven't had this as an agenda item for any of the webinars, so this is a new one. We'll talk about the skilled nursing facilities, swingbed rates. We'll talk about those, the RHC consolidation issues. This one we've talked about before, but we have, again, just some reminder items on that. The certified registered nurse anesthetist, CRNA, we wanted to talk about that a little bit. We did cover that. It's been a couple of years now, a few years, but again, just some refresher items. And then we always wrap it up with just an overview of current things we have out on the website, some webinar items, and YouTube training resources. And we should have plenty of time for any questions. And one thing I'll mention with that, if you have questions on a topic as we're going through it, feel free to share those questions or post them to the chat area while we're talking about it. We can address the questions at that point. You don't need to wait until the end to bring it up. So with that, let's dig into the S10 uncompensated care audits. Now I have a few slides. Again, back in February, we went through S10. We focused on it, just that topic solely. So some of this is refresher, but there were a few important things I wanted to really focus on. But we know this year we're dealing with the federal fiscal year 2023 cost reports. So the cost reporting period is beginning between 10/1/22 to 9/30/2023. Nothing new there. It's for all the DISH eligible hospitals. So any hospital reporting DISH on E-Part A line 34. Now that's even if you've amended your cost report to add DISH. So maybe your first version of the as submitted cost report did not have it, but now you've added it in. We will have to audit that as well. And now that does also include SCH and MDH providers. That's a point of contention that has always come up. We hope CMS might change that, but so far they have not. And here's just the Federal Register excerpt that talks about that. It's back in 2020 where that question was addressed, and they answered that yes, the sole community hospitals do need to be included. Now, we know this is the first year the cost report periods beginning on or after 10/1/22. This is the first year that we're dealing with these new S10 instructions. Now, you've already submitted the cost report, so for providers that are submitting cost reports, you're already in your second year, and depending on the year, maybe even your third year, if you have partial years or whatever. So you've already dealt with the new instructions, but this is the first year we're auditing them. So we have the new exhibits, the new exhibit 3B and 3C for the charity care and total bad debts, respectively. But if you look at the instructions for 3C and 3B, here's a reference to the sole community hospitals. And this is what adds a little bit of confusion to the whole SCH issue, because in exhibit 3C, it says if a sole community hospital is eligible to receive a dish payment, so they have dish on E-Part A, but worksheet E-Part A line 48 is greater than line 47. 48 is your hospital-specific payment. If that's greater than your federal payments on line 47, then it specifically tells you not to complete an Exhibit 3C listing. So it says you don't need to submit the S10 listing per se, but that still does not mean we don't need to do the S10 audit. You just did not need to submit the S10 listing at the time of acceptability, which is a big disconnect. They're two separate things altogether. We had this discussion back in the February webinar as well. Two completely different things that CMS hasn't fully joined together yet, and it causes quite a bit of confusion. There are the cost report submission requirements. What do you have to do to not have your cost report rejected? And that includes submitting the listing unless it tells you you don't need to. And it also tells you, hey, what listing do you need to submit depending on the time periods? So that's one requirement. But then the other issue is, what do we need to do during the time of the S10 audit? And again, unfortunately, the rules don't always sync up. And that's what we're dealing with here. So this one basically says, in this situation, you don't need to submit the listing, but that does not mean we don't need to do the S10 audit. So that's the point we're trying to make here. The same thing applies to the critical access hospitals. We are never, well, I should say never, but certainly not right now, and I highly doubt ever, we are not doing an S10 audit from this point forward. Again, there's no need to, there's no uncompensated care payment. But the odd thing is the instructions still say cause must fill out S10. This is basically a residual issue from back when we were doing the EHR audits. It was not an S10 audit per se, but it did audit part of S10, a little bit of S10. It used that payment. So again, yes, you technically need to fill it out. We're not going to be looking at it at this point. Is anybody else seeing it? It says sharing, and I see it in the preview window. Is anybody else able to see the screen? You see it? Okay. Yeah, Stephanie, I'm not sure. Yeah, it should be sharing. You might need to disconnect and rejoin to be able to see it, or possibly just refresh the browser there. So yeah, the critical access hospitals, again, hopefully CMS updates that. There's really no purpose for it at this point. Now the other thing, do non-dish acute care providers have to submit exhibits 3B and 3C? So if you do not have dish, report it. Now, if you take a look here, exhibit 3B, it says, well, this is that reference to SCH. If the SCH is eligible to receive a dish payment, but E-Part A line 48 is greater than line 47, and the same thing as with exhibit 3C. So the non-dish acute care providers, we're not going to be auditing them for S10. Now here, it says effective for cost reporting periods beginning on or after 10/1/18 for dish eligible hospitals reporting charity care basically on S10, a cost report will be rejected for lack of supporting documentation. So that's the acceptability requirement at this point. So here's the summary of it. For charity care, the regulation requires it at the time of acceptance. So, and it's been a requirement. It's just a question of what template was needed. So it has been required if it's DISH eligible, if it's been reporting DISH on E-Part A, otherwise it could be rejected. For total bad debts, again, it's required, but it's not part of the rejectability portion. So that's the disconnect there. We won't reject for it, but it's needed. And then there's that exception for the SCH hospital specific rate. So it won't be rejected there if you have an SCH where the hospital specific payment is higher than the federal. It won't be rejected at the time of acceptability, but we'll still need it to perform the S10 audit down the road. So this is just a summary. It's not the first time we've talked about this. You'll have this in the last month's slides as well, but I just wanted to refresh it again just because the questions still come up. So it's unfortunate that there's this confusion and disconnect with the instructions, but until they get changed by CMS, we just kind of have to deal with it there. And the other thing here, so now this is a completely different issue. This is Exhibit 3A, the Medicaid day listing, which of course has nothing to do with S10, but I wanted to bring it up because this one also gets asked for the same reasons. So if we take a look at the S2 instructions, and that's the control question, here it says for lines 24 and 25 where the Medicaid days are reported, again, we're going back all the way back to 2018, a cost report will be rejected if it doesn't have the DISH listing. And here's Exhibit 3A, that's the DISH Medicaid day listing. And if we take a look at the regulation, it says for hospitals claiming a DISH payment adjustment, so then you need to have the DISH listing. That makes sense. So you might have days there, but if you don't have a payment, you can have days, but maybe you don't qualify for the payment. You don't have high enough of a Medicaid ratio and or SSI ratio to qualify for the payment. So the regulation specifically says if you don't claim a payment, then this doesn't come into play there. Whoops. And then Exhibit 3A, again, we have that whole SCH issue. If you're an SCH, but it really doesn't matter because your hospital-specific payment is higher than the federal payment, then you do not need to complete the Exhibit 3A listing. So again, the language, the instructions throughout the different levels of policy and regulations are just at a little bit of a disconnect. So the summary here, if there's no DISH claimed whatsoever, regardless of the fact that there are Medicaid days, then we don't need a detailed listing at acceptance. If there's DISH claimed, but you have that sole community hospital and those hospital-specific payments are higher, then there's no detailed listing required at acceptance. But the key thing to remember here is regardless of what your DISH looks like at acceptance, SSI ratios change. You generally won't have the right SSI ratio when you submit your cost report because it's not available yet. So at the time of desk review, we update to the new SSI ratio, and that very well may bump you into DISH eligibility even though you didn't have it before. There might be a few other things that could impact your DISH eligibility as well. So if you did all of a sudden become eligible for DISH, then of course we would need a Medicaid day listing at that time. Your cost report was already accepted, and that's fine, but we would need a Medicaid day listing to actually review your Medicaid days. Otherwise, of course, we wouldn't be able to reimburse you for DISH at that point. So just a disconnect, but not so much disconnect there, just things have changed by the time of final settlement. So everything up to this point has been talked about. It's just the questions still come up. So we wanted to refresh it, remind everybody of it. Now, the issues that came up during 2025 specifically, this year's audits, and this part right here, we talked about last month or last quarter, and there was some confusion and some unfortunate disconnects there with CMS. So the question of what template to use. Now, we know for sure the T18 template was absolutely required for the cost report submission and acceptability. That's in the instructions for fiscal years beginning 10/1/22 and after. No doubt the T18 template had to be submitted. The problem was the S10 audit for us, for Max, was never updated, and our requirements were never updated. There's a certain piece of the old template that we absolutely need. And CMS and the S10 contractor that works with Max, kind of the liaison between CMS and Max, if you will, confirmed that we need the old S10 template. Now, that's what we talked about last time during the last quarterly audit. Now, the problem with that, of course, is that providers had already submitted with the T18 template as they were required to at the time of cost report submission. And then now they're being told that, well, now we also need the old template like we've had all along. So, of course, that's a lot of extra rework and just a lot of extra documentation. The thing is, we cannot just accept the T18 template, unfortunately, because those S10 audits, our S10 audit program was not updated. So we had multiple confirmations from CMS saying just that. We needed the old template, just like we've had all along. So after working with them, and again, all the Macs got the same information, what it boiled down to is if you submitted with the new template, we can work with you to get just the information we need from what would have been the old template. And specifically, that would have been the transaction code. That's the basic thing we need from the old template that's not on the new template. So if you were able to submit, let's say you submitted the T18 template, if you were able to just add a column on showing the transaction code, how you wrote that claim off. Did you write it off as bad debt? Did you write it off as charity care? Then we can allow that. We can work with that compromise. We got permission from CMS to do that, basically. But we just using the T18 template, we cannot use because we won't be able to complete our audit program without that step. And that's a pretty big step, basically. In fact, to give you a little more information, without this piece of information, this transaction code, what would happen here is we cannot go through some of our initial steps and clean up the listing right up front and get assurance as to whether that listing only includes charity care or only includes bad debt. That's what we need to do up front so that by the time we get to the point of detailed testing and sampling and then later extrapolation, we are sure, we have assurance that we're not going to find any of those errors where, hey, this was actually a bad debt on a charity care listing. We don't want to find those errors at that point because then we'd be forced to extrapolate. We'd rather find those errors up front to clean up the listing. So that's the purpose of the transaction code, and that's the risk if we don't have the transaction code. The only thing we'll be able to do is extrapolate for what should have been an obvious error that we could have cleaned up ahead of time. So what we're hoping is that CMS is able to change the audit program next year and or change the template requirement. But the problem with that, though, is that, again, you've already submitted the next year's template because that year's already passed as well. So whatever they do now, even if they did something today, that at best is still going to impact 2 years from now. There's just that built-in delay just due to when we end up auditing something that you've already submitted. So we hope that there's more clarity one way or the other. But again, we're kind of left with whatever we get from CMS down the road. So more to come there. The next issue, which has been evolving a little bit, this is another piece of confusion, some disconnect in the language, or just some inconsistencies, I guess is the good word for it. But line 25 versus line 25.01. So prior to this year, CMS had line 25. They've used that. It was an unfortunate mechanism, but line 25.01 is the new one. It's the same basic mechanism for a different reason. So line 25 is for the non-covered portion of an otherwise insured patient, specifically a Medicaid patient. And since this is a non-covered portion, it's definitely not going to be a deductible in coinsurance because that's only for covered portions of a claim. So this portion is going to be charges. So it's a partially non-covered. And I want to stress that this particular issue, when you have a claim that ends up falling on line 25, it can only be partially non-covered because it's due to the fact that that claim exceeded the length of stay limits. That means that particular stay went longer than it was supposed to. It exceeded that stay's length. So just logically, some of those days had to have been covered. Otherwise, that makes no sense. A length of stay means some days were covered and now all of a sudden the later days are not. So the claim had to be partially covered and partially non-covered. So that's the reason for the non-coverage. Again, it's just illogical to be fully non-covered due to this length of stay limit. I'll get to that point later, why that matters, why that distinction matters. So again, this is just for Medicaid length of stay limits. That's the only thing you should find on line 25. Here's the other thing with this mechanism, though, that is so important to stress. Anything that you put on line 25, any charge amount that goes on line 25, that same charge needs to be commingled with everything else that's on line 20, column 2. So the entire claim, both the covered deductible coinsurance portion and the non-covered charge portion, must be reported in line 20, column 2, which is the insured column. So again, the whole thing goes there, and just the charge portion goes on line 25. That's critical for the mechanism to work properly. So let's get down to line 25.01. The good news is the mechanism is the exact same. Again, the whole claim goes on line 20, column 2, and just the non-covered charge portion goes on line 25.01. The only difference between line 25 and line 25.01 is the reasoning. Now, the difference here is that this is basically every other non-covered portion of an otherwise insured patient's claim except for the Medicaid length of stay limit. So that's the reason for non-coverage. This situation, however, can be either partially or fully non-covered because it's not a length of stay limit, so there's no logical boundary there. The thing I want to mention here, and I think I have it on the next slide. Yeah, so going into this whole fully non-covered, because when you first think about it, and I will mention, when I first went through this logical analysis, when this line 25.01 first came out, my first thought was that if something is fully non-covered, to me, that felt more like uninsured. That was my first thought, and I might have even mentioned that in another webinar. But as I read through the instructions and did the analysis more, that's not the case. That's certainly not how it's written. So for that reason, line 25.01 can be either partially or fully non-covered. So what I mean by that is that fully non-covered does not equate to uninsured. If they have insurance, but for some reason the entire claim was non-covered, they're still technically insured. And let's go through the logical analysis of that and why I believe that, why that's the case. If we look at line 20, column 2, the instructions under insured patients, it goes through the detail of what amounts should be written off in column 2. Specifically down here in this fourth kind of bullet point, it says charges or the portion of charges. So the fact that they have or the portion of charges, we know the portion of charges means some, but charges would mean all. So basically this is saying all or some, fully or partially. So this verbiage right there tells us that it can be fully non-covered or partially non-covered. And then if we go down further, this is where some more of the confusion comes up. And CMS really, I think, they do need to change this. This is very ambiguous or convoluted. But if you take a look at the S10 template for T18, if you look at column 6, which, by the way, let me see, I think I have that open here. Yeah, let me pull it over here and show you where this is. So this is a T18 template. And I'm talking about this column 6 right here. It just says insurance status when the services were provided. It's either 1, 2, or 3. And then they give you this little bit of instruction right here. And that's what I'm pointing to. That's what I'm mentioning right here in this section. So it says enter 1 to indicate the patient was uninsured, did not have any insurance coverage. Now I have that bolded and underlined because I think that's a poor use of the word coverage. I think that's confusing the whole issue, and I'll explain why in just a bit. I think what this should say is did not have any insurance, period. Don't use the word coverage there because it's not really talking about coverage / payment. Enter 2 to indicate the patient was insured but not covered when the patient, they had insurance, but they didn't have a contractual relationship. They had insurance and the services provided were just not covered, period. They're non-covered services. Every insurance company has certain things that are excluded. They had insurance coverage and the patient had exhausted their benefits. So similar to that whole length of stay type deal. Had general coverage through Medicaid, but was not covered for this particular stay due to exhausted benefits or non-coverage. There's a little bit of confusion here why CMS decided for the Medicaid piece to explicitly call out for this particular stay. I don't know why they wouldn't do the same thing for other insurance. So hopefully they can clarify that. And then enter 3 to indicate this patient was insured. So what it boils down to is code 2 should be used for insured for fully non-covered situations. Code 3 should be used for insured but partially non-covered situations. Line 25.01 can be either of these two depending on the situation. Now, regardless of how you might have filled it out, now, what code you use, the only thing that really matters is that the auditor knows which one is which, what you intended. So as long as you communicate your intent with the auditor, that's going to be fine. And hopefully down the road, we can get CMS to really, truly tell us what they wanted this to be used for, because right now it's just very ambiguous. I would say go forward with this instruction right here for line 25.01, but down the road, we hope CMS can update this. So I'm spending a little bit more time on S10 than I really intended. We're going to wrap up our S10 by December 31st, and then next year we'll start early February, and then we'll have more information hopefully at that point. So, and yeah, see, we have some questions here. Yeah, let me go to these real quick. Yeah, for the PowerPoint, yeah, the PDF version. So I sent that out to everybody on the list, but I'll send it out as well to anybody that might not have received it. Anybody that's on the roster that attended will get a copy as well. One thing I will say, though, I get a lot of bounce backs from different emails. A lot of them say it was suspected as spam, so the mail rejected it basically. So if you have a way of going into your IS area, IT area, and adding our domain as a kind of on the whitelist or the safe list, if you're not getting anything and you've been added or you attended and you're still not getting anything, then that might be the case. If you want to send me an individual email and I can respond individually, that might bypass the spam filter. If that's the case, that might be why you haven't gotten anything. But I'll definitely be sending these out after the fact as well. And to your question of the workers' comp and auto insurance, so if we go back here, so that should be this code 2. So that's the whole non-contractual relationship. That would be that situation. They're insured but not covered. So this whole non-contractual relationship, that's exactly what that is. Workers' comp, auto insurance, all of that. So it's still insured, but it's not covered. And then let's see, for the transaction code. Oh yeah, so it's mainly for the charity care. You know, it would be helpful on the bad debt, but it was never a requirement, as you said. So yeah, just the charity care template is really where it's needed. And using the new template with the transaction code, yes, that'll be accepted for this current round of the cost reports. Oh, for the next round, 6/30/25. So it'll be, I mean, certainly for the cost report submission, it'll absolutely be accepted. For the S10 audits, I mean, I don't think CMS would go more stringent for our next S10 audits. So if anything, I think they would become more lenient. They might remove the transaction code requirement at that point. But yes, for the acceptability, you're right. That would be certainly acceptable. Oh, certainly. And here, I'll put my email address in the chat here. Whoops. And that's not letting me chat for some reason. Just 1 second here. Okay, now there's my email address. It's in the chat area, so you can just send that to me, and I'll send that right back to you there. And that might bypass the spam filters. Okay, so we'll move on to the next topic, which some of this I can run through pretty quickly to kind of catch back up. So DISH appeal / reopening projects. This first one, I have a few slides, but my main summary is that this is done. The CR 13294, what we sometimes refer to as the Alina Part C Day issue, that started back in March of 2024. The due date was March of 25, March 25th of 25. Most of those were zero settlements, but there were some that, especially those that were paired up with this CR 9311, CR 10487. There were a few different CRs from years ago that were closed out with this. Those were not zero settlements. There were also some new kind of last minute federal remands thrown into this. Those were mostly zero settlements. But the point is, these are all done at that point. So anything related to the whole Part C day, whether the Part C days were included in the SSI ratio or Medicaid ratio, those are done. Those were done as of March 25th. So that change request is done. And again, just a couple slides just showing some links and some information on it. But the point is, they're done. There's stuff still on our website if you wanted to see the history of it. Moving on to the current DISH project, which is the SSI realignment piece. Now, this is change request 13413, and it was dated July 26th of 2024. So we're just about entering the first year from that date. This particular change request dealt with SSI realignments prior to 10/1/13 fiscal year begins. We have the link to the CMS website with their actual, with the CR itself. Now, this was effective July 31st. Now, the due date for any SSI realignment submitted under this change request is 24 months from the receipt of that SSI realignment request. Now, the main reason for this lengthy time frame is that we're talking about requests all the way back to the mid 80s. And I have the specific dates in a later slide. And a lot of these, especially, well, once you get earlier than the 255210 form set, and certainly before the 96 form set, it gets very difficult to find the data, first of all. But before the 96 form set, we can't use the electronic cost report files. They're just not available to be used in a modern Windows environment. and we can't HICRIS them, we can't do anything with them. So you have to manually use that data. But even the 96 form set, there are a lot of files, especially with all the MAC transitions over the years, all the FI transitions over the years. Finding the data is difficult. Reconciling the data due to the software changes over the years, clearing the level 1 edits, it's very, very time consuming. And we've had a lot of situations where we've had to rebuild cost reports from HICRIS extracts, which is very time consuming there. So this is a large reason for the 24-month time frame, aside from just the bulk of requests in general. So the other thing about this, though, so aside from this 24-month time frame, even if it was a nice clean unit, now obviously the ones that come in where we have the file, there's no problem. Those are certainly the ones that we're going to try to get done as quickly as we can. We have the file. It's just a matter of it's in the queue as soon as it can get done and get through the NPR package, the review, all of that, and get reimbursed. But the ones where we have to rebuild the cost reports and do all that, those are the ones that will take more time. They'll be close to the 24 months. We hope none of them ever get too close to the 24 months, but they would certainly be the ones that would take longer to do. On the other side, though, in that CR, if you read through that change request, there are a few different scenarios where CMS requires these units to be sent onto them for approval. And one of them is if, let's say you submit a fiscal year begin and end, and it doesn't match what CMS thought the year was going to be. So when they published their SSI ratios, the realigned SSI ratios, they thought they knew all the years for the providers. But if it turns out you had a different year, then of course they're going to have to recalculate a different SSI ratio. There are a few scenarios listed. That's just one of them. So we have to wait for their approval and possibly their new data. The time frame is 2 years from the receipt of their go-ahead, their approval, their new data, all of that. Again, we hope none of them ever get close to 2 years, but that is what the time frame is. And let's see. Just a quick little discussion of the SSI ratio in general. So it's all about a realignment, and you could either use the standard SSI ratio that CMS develops, which is based on the federal fiscal year, or you can have an SSI ratio calculated based on your particular cost reporting period. Now, this 42 CFR 412-106B3, this is the regulation that actually defines the ability, or defines and gives rise to the ability to request an SSI realignment to begin with. And what it basically says is you have to include your hospital name, provider number, and cost report period end date. You can request it once per period. And the thing is, once you request it, it's locked in. It becomes your official SSI ratio. That's an important thing to note. Now, again, the whole thing about a realignment is you have the same data. Every month, for example, is going to have a certain number of Medicare SSI days, certain number of total days. So it's all a matter of which range of time are you using. For the federal fiscal year, you're going to be using October, September. For, let's say this provider has a calendar year, they're going to be using January through December. So the ratio is going to be a little bit different, most likely. I mean, I guess it could be exactly the same. That'd be a big coincidence, but most likely one's going to be higher than the other. It's not always going to fall the same way. Some providers, for a particular period of time, would have a higher realigned ratio. Another provider might have a higher federal fiscal year ratio. So realignment does not benefit every single provider and every single year. That's the key thing to note, but it certainly can benefit some. The other thing to keep in mind, though, is that it might not even impact your dish at all. If you've already been capped, or if you're below the threshold and a little bit of a change still keeps you below the threshold, then it's not going to impact your dish at all. That's not saying you can't request a realignment, but it would be a zero settlement if it just didn't impact you. So you can still submit it. We can still process it, but it's always important to understand how it's going to impact your dish. And certainly, if it's going to reduce your dish, it would absolutely behoove you to not submit that request, because we'd be forced at that point to process it. That would now become your official SSI ratio, and we would have to process it, and that would reduce your dish reimbursement. So be careful with that piece, certainly. Now let's go to the other SSI ratios. So again, this CR is applicable for pre-10-113 federal fiscal year begins, or fiscal year begins, I should say. But for anything beginning 10-113 or after, we're still under the same standard process. Whereas you send the request to us, we have to send it on to CMS, and they recalculate it and send it on to us, and then we process it under our normal 180-day time frame. The thing is, there's the delay waiting for CMS. With the pre-10-113s, they've published all those ratios, so there's no delay in waiting for them, except for those few scenarios I talked about. So the data's there. Providers can see it. Auditors can see it. We know what the ratio is. But for anything 10-113 and after, they have not published them. I don't know if they will, but they certainly have not yet. The other thing to note here, the big change with this CR is there is no 3-year time frame for any of these. That's why we are seeing some of these all the way back to the 1980s for that. And here's the specific time frame. This starts all the way back in the 10-1-1987 fiscal year begin, which is federal fiscal year 1988. Now, that's not the very beginning of DISH. DISH actually started May 1st, 1986, but the realignments didn't come into place until a year and a half later. So that's why we're starting there. Here's just a little blurb with our website where we have the CR 13413 article. And let's see, going back to the questions. Yeah, certainly you could submit. Yeah, you could submit additional listings or additional fields on that listing. There's nothing that'll stop that. Yep. And if you're talking about like the MECRF process, you can have additional data. In fact, CMS didn't fully lock it down. They basically gave you a minimum requirement. They said your template needs to have all of these items, but there's nothing saying you can't have additional items or you can't have, just additional items. They haven't locked it completely down yet. I don't know if they ever will. I kind of doubt they ever will say you must use this exact template, this exact spreadsheet. I don't see them going to that point. And if they do, it'll be probably quite a ways down the road. Okay, so on to the CR 13413 again. For submissions, if you want to submit them to me, either the email address I posted in the chat area or just the audit.advisement@wpsic.com. Now, here's the requirement from the CR. It must contain a provider number, fiscal year begin, and fiscal year end. That's all we need to see. And of course, it has to reference that you want the SSI realignment. And you can include it in a mass submission. You can have one letter or one email that has, 10 years for a provider, whatever. And as soon as I get that, I'll send a confirmation email. And I already talked about the time frame. The other thing, the last piece I wanted to mention here, for the last few webinars we've had where I've brought this up, we referenced this pending Supreme Court case that might have caused a lot of providers to hold off on submitting their SSI realignment requests. It was, even though it had nothing to do with the realignment issue itself, it had to do with SSI, really the SSI ratio in general, because it had to do with SSI eligibility. And this case was the Advocate Christ Medical Center versus Kennedy now. And this was now decided back in April of this year. It was decided by the Supreme Court in favor of HHS and CMS. So that's done. And basically that obstacle, and nothing is going to change with the SSI ratio. So if you were waiting on that decision to submit your SSI realignment request, that wait is over. There's nothing holding you back from that angle. So the point is, if you haven't submitted your request and you want to, if you want to get in line, basically, the sooner the better. So feel free to submit those, and that way we can at least take a look and see what do we have to do. Do we have to start gathering the data? Do we already have the data? Can we get you in the normal review queue? So basically, the sooner the better. That the sooner you get it in, that just means the sooner the reimbursement is going to go out. That's kind of what it boils down to. So again, just send it in to this email address. And with that, we'll move on to the next topic. So this is a new one that we haven't really brought up, I don't think, in any of the webinars, not this specific topic, certainly. So this deals with the graduate medical education and the indirect medical education, FTE count add-ons, and the cap adjustments. I know I don't have all of that in the title of this slide, but we're talking about two separate but related items. It deals with new programs in general. Now, just as a heads up for what I'm talking about here, we are going to be having some updates to our website, and we're going to have a form that's going to be available in the very near future. I'm going to reference that form, and I'm even going to show it on the screen, but we have to make some tweaks to it because we have to put an ADA compliant version of the form out there, and that takes a little bit of tweaking to get into that standard. So I'll bring up a version of the form, and then we'll get both copies out there for everybody that wants to see it. But this deals with, well, we'll start off with the easy piece. This is where we have the FTE count adjustments for the initial years of new programs. Now, I've got some references here for where you would find this for the different types of providers. Now, I do want to stress here, we're talking both GME and IME separately. There are different rules for when FTEs or how they count for GME versus IME. So what we're doing here does need to be done separately. We did just recently get confirmation from that from CMS because it was a little ambiguous in some of the verbiage in the instructions. So I'm going to open up just a blank cost report here and kind of just show you one of these, show you the basic mechanisms here. And of course, this only applies to the teaching hospitals. I know that's a relatively small subset of all hospitals, but let's just look at E Part A, line 16. And actually, before we get there, oops, don't want that. Okay, if we take a look, we'll do IME first. So we have, I'm just going to do a quick run through the basic mechanisms of the count versus the cap. So at the very top, we start with the cap itself. We establish a cap. There's your base year cap, and then you have a few different cap adjustments for a variety of reasons. You have a cap adjustment here for the CAA 2021. Here's the cap adjustment for the new programs, which we're going to talk about in a bit. Here's another rural track cap adjustment. Here's a cap reduction. So there are a variety of cap increases or decreases. Here's an affiliation agreement. So you start with a cap and then you adjust it up or down. And then you compare that, you can see all these different cap adjustments. And then after you have your final cap, you take a look at your actual count for the year of FTEs. And then if your count is above the cap, of course, you're capped. You're stuck at whatever the lower of the two numbers is. Now we're down to this 16. We've already capped it. Let's just say our FTE count was 20, but we were capped at 18. So of course, 18 would be the number that flows down here. But the thing is, if you had a new program and you were in the initial years of that program, you hadn't quite established a new program cap that would have added on up here, then you get to add it on down here after the cap. after you've already applied the cap. So it's after that point. And that's what we're talking about right here. There's actually two different things that allow you to do that. If you're in the initial year of a new program where you have not yet established a cap, or if you have residents displaced by a program or hospital closure, those two things get added on after the cap has already been applied. And then, of course, you have a rolling average, which is kind of another type of cap. It's a prior year type cap. You're going to find the same basic thing on the GME side, but I just wanted to set the stage for what we're talking about. We have two different things. These FTE add-ons after the cap, and then the second thing we'll talk about are the FTE cap add-ons right here. Line 6. So two separate things. That's where we are on the cost report, and you'll find them again, the same thing in E-4, the same thing in all of these other lines. So that's where we are, FTE count adjustments for the initial years. And by the way, if anybody's referencing the slides I sent out, I tweaked the verbiage of this just to make it a little bit clearer, these two completely separate things. So when you get the new copy of the PowerPoints after the training, you'll see these slight adjustments. Now, the documentation we need for this, that's the whole point of bringing this topic up. When we are auditing it, there are certain things we're going to need to see to be able to audit it properly and to allow it. Now, of course, IRIS is your basic requirement. You need to submit the IRIS even to have your cost report accepted. So that's number one, but that's not everything. That doesn't give us absolutely everything we need. So there are certain other things that we need. Number two, any resident FTE count listings or calculations. Some of this I'm going to read just to make sure I get the clear verbiage. Any listings prepared to support the claims on the cost report for the current year FTE counts. And specifically, we're talking any of the residents in the initial years of the new programs. Now, keep in mind at this point, we're talking about, and again, ignore the label because it's very broad. We're talking about two separate things here. We're still on this piece, the count adjustments after the cap is already applied. So any listing you might have or calculations that you have separate from the IRS. Copies of the letters of initial and or continuing accreditation, because of course, no matter what your cap is, no matter what your count is, you have to have accreditation for that, for the program. There's just no way around that. So your program has to be accredited. Otherwise, the whole thing is disallowed. Number 4 is a big one. And number 4 is a big one. Source documentation of the complete master rotation schedules. So a lot of times when you see rotation schedules, you might be thinking from your provider specifically. But the problem is the FTEs, the interns and residents that rotate throughout your program, in many situations, there are multiple providers in your group that are training those residents, interns and residents. The master rotation, by definition, is every provider that these residents rotate to. We need to see where they are at different points. It's not enough to see just your view. We need to see where they are throughout their entire rotation. Because if we're going to be establishing a cap eventually, we need to make sure, first of all, that they're not being double counted anywhere, but we need to see where they are for 100% of their time. So that's what the master or block rotation schedule is. Some entity in your group should have that view. There needs to be somebody in control of that, of where they're going at all times, to obviously make sure they're not double scheduled somewhere. Somebody needs to be sure of that. So we need to see for all new programs and all academic years spanning the cost reporting period. So number 4 is the big one. And then, of course, number 5 is just really the catch-all. Any supplemental information, any descriptions, explanations. This just goes into a lot of detail for that. Now, the next part would be the FTE cap add-ons. This is the cap add-on specifically. The first one was the FTE add-ons after the cap. This is now you've built a cap and we're adding on to the cap. So going back up here, we have 5.01 and 6, E-part A, line 5.01. Here's one of them, and then 6 is the other one. So a couple different things. Again, all of this is you're adjusting your cap before you get to your final cap. These are the two lines we're talking about. And you'll have the same thing on E-4, E-3. You'll have all that same stuff there. So some of this documentation is similar, but there's maybe a little bit more verbiage here. So number one basically says anything you have not already submitted for the FTE count piece, because now we're in the cap building period. And I'm going to open up a spreadsheet in just a bit. This is the template that we're going to be posting to the website or making available to you one way or the other. So this is the cap building period, and it helps to define what we're talking about. That it's a 5-year long new program FTE cap building period. We'll see that in just a bit here. Any new program FTE cap calculations, so anything you've done internally to help you identify that number to report on the cost report. And then number 3 is just saying, hey, we have this template. It's not a required template by any means. We can't just build something and require you to fill it out, but it's something that might help you. That's the point. If you have your own version of a form that you think does a better job, feel free to use it. And with that, let's go ahead and open that form up. But before I do that, just one last little thing, and then I'll open that form up here. This is just kind of showing the difference in responsibilities. Of course, with anything reported on the cost report, it's always the provider or consultant's responsibility to report it, first of all, to gather the data, report it on the cost report accurately, and have supporting documentation. And the MAC and the auditor, that's their responsibility to audit that submitted data. So that's just showing that. The thing is, if there's no supporting documentation by the time we get to the point of audit, now again, it's not a required template. There's no specific thing that's required, but we have to have sufficient documentation to be able to audit what that number is and be able to come up with that same number. So if we can't, after communication with you back and forth, if we can't get that documentation, then of course we wouldn't be able to allow the number. That's just natural. That's anything on the cost report. We can't just allow a number blindly. We need to have the supporting documentation for it. So let's take a look at the, and I will say draft right now, it's mostly done. There might be a few tweaks. There's certainly going to be some tweaks to put it into the new format, the ADA compliant format. But this just basically, the first part here, let me zoom in a bit. It's just basic information for this new program. What is the new program? What's the IRIS residency code? When was it accredited? When did the resident training first begin? What's the minimum accredited program length? And how many positions were you accredited for? And again, we're going to be needing documentation for these things. Now, all of this information is going to come from your records, specifically that master rotation schedule. And again, it's separate for DGME and IME. We need to see for each year, how many FTE counts did you have? You're building up an FTE cap through your 5-year period. And the definition, if you read through, I think we have a reference. In the instructions, we have a reference to the Federal Register that defines this. But it's the 5th year of the first new program's existence at all of the hospitals to which the residents in the program rotate. So I know that's a kind of a lengthy discussion there. And what it ends up being is the highest total number of FTE residents trained in any program year. So you have that 5 years to prove it. And you're multiplying it by the 3-year period in this case, the minimum accredited length. And that gives you the FTE cap adjustment for all hospitals. But again, in many situations, Well, and of course, it's capped by your number of accredited slots. So even if you had 33, if you're only accredited for 30, then obviously that's your limit. So now you have 30 in this scenario that's going to be allocated or apportioned to all of the providers in this whole group that they were rotating to. So that's where we need that master rotation schedule to be able to identify how much of this cap should go to each of the hospitals. Where were they rotating to throughout these different periods? And that's what this template will help to prove. But of course, there's documentation behind this template, and that would be your master rotation schedule. So that's what we have here. And again, we'll put it out we'll make it available on the website it'll have an article with it. It'll have some instructions, and we probably will have a YouTube video going through this in a little more depth, maybe with an actual example of a few, not real providers, a few just template providers, if you will, kind of showing some situations. So that'll be available for anybody that needs it. We've seen this issue start to come up more and more with a lot of the new programs, which is why we decided we would build a template like this. We have a medical education expert, a few of them, certainly one, and we have a couple others that are involved with it. So more to come on this. But that is our discussion for the GME, IME, FTE cap adjustments and just the FTE add-ons themselves. So now we will move on to the next topic. I'll check to see if there are any questions at this point. Okay, nothing yet.
This is Louis. So real quick on the new residents and then the ACGME. So if you had, say, two programs, the ACGME said you get 10 FTEs and you only had your highest year was 8.
Yep.
And then there was another program where your ACGME is, say, 6, but then you had, say, 9 FTEs one year as your highest. So you'd have 1 FTE above both. Are you saying that each ACGME and then the residents underneath it, that would have to be assessed individually, or would you do it in the global?
Each program would be handled individually, correct?
Okay.
So,
okay.
yeah.
Thank you.
No problem. Good question there. Okay, so now we'll move on to the topic of the skilled nursing facility swing bed rates. Now, just the definition of this, I remember when I first heard this way back when I started, it just seemed odd. I didn't know what a swing bed was. I heard of the providers, but basically it's a bed that can be used for multiple purposes depending on what it's needed for at that time. So it figuratively swings between an acute care usage and a nursing facility usage as it's needed, instead of having to have 2 separate facilities and that they can transfer the patient to. So it's a continuing level of care for a patient. They're discharged from the hospital. They no longer need that acute level of care, and they're transferred to the skilled nursing facility, even though they might still be in the same technical bed. So it's just a different level of care that they're needed. Now, there are 2 different things here we're going to be talking about. The skilled nursing facility, the SNF, now that's basically the Medicare level of care. And then the NIF, nursing facility, and maybe I shouldn't say level of care, certification, Medicare certification, and then nursing facility, the NIF, and that's basically everything else. Non-Medicare, it can include Medicaid. So the reason it's so important, these rates, is that all the routine costs of the hospital and the swing bed are by their nature commingled because the beds are commingled in the same area. That's the whole point. They're not distinct. If they were, we wouldn't have a swing bed. They'd be completely different areas. They'd be completely different beds. So we need to find a way to carve these out, carve the costs out. Now for the critical access hospital, this is very important because the costs are reimbursed separately on cost. For the acute care, it's still important, but it's not going to drive reimbursement on that current year cost report. CMS still needs the data for accurate rate setting, and that's why that carve out is still important for them, and that's why it's still required. So we have two different things. We have the SNF and the NIF, and both of them have swing bed rates that need to be reported in the cost report if you have those types of days and beds to begin with. So the swing bed SNF rate is often referred to as the Medicare rate, and this is going to be found, it's published by CMS, so it's easy to find, it's easy to get, and it's a regional rate, but it's not state by state, it's region by region. There are 9 regions. And it's found in CMS Pub 15-1, Section 2231. So it's in the policy manual. And at the beginning of this policy manual, you'll find out which state goes into which region. Now, this screenshot was just from like a week ago. As of then, and I'm sure as of today, 2024 is the latest rate that's been published. And they're calendar year based. That's the other thing. So on your cost report D-1, which is where these rates end up getting reported, specifically line 17 and 18 for the Medicare swing bed rates, SNF rates, they're calendar year. So if you're not a calendar year provider, you're going to need 2 of them for your different portions of the period. Now the swing bed SNF rates are only needed for the acute care hospitals, and the cost reporting instructions are pretty clear about that. In fact, I believe you get an edit if you try to report a swing bed rate for a CAW. By the way, just to give you let's see, do I have that? The reason they're not needed for the CAW is that the only reason they're put here for the acute is to try to carve out how much of this overall routine cost is really swing bed cost, so that CMS knows what they should build their SNF PPS, their swing bed SNF PPS DRG rates on, or actually the RUG rates, the PPS rates based on, and then how much of that cost goes into the normal hospital DRG rates. So that's what they use that for. But for critical access hospital, for the actual cost reimbursement, they calculate a cost per diem using the cost reporting data itself, the days, the costs, so they don't need a predetermined rate like this. So that's why this is not used for the CAW on the SNF swing bed side. For swing bed NIF, though, this is used for both. I refer to it as the Medicaid rate, but it's really everything other than Medicare. This is still calendar year based. It's reported on 19 and 20, which let me just quickly show you here. It's really convoluted. If you haven't focused much on D-1 before, the first time or two you look at it, it's kind of looks messy. So let's look at 17 and 18, 19 and 20. This right here is where these rates are reported. This part's easy. 17 and 18, Medicare swing bed SNF up until December 31st of the year, and then after December 31st of the year. And then 19 and 20 is the swing bed NIF rates. They even refer to them as Medicaid here as well, but it applies to everything non-Medicare. This is what you enter, but then they're going to be multiplied by the days that are reported up here, the swing bed SNF or NIF days that are reported up here. So just wanted to show you where they go. But here, this rate is not published by CMS, unfortunately. MACs have to get this from the state, and in most cases, we actually have to do a lot of work with it to get it where we want it to be. We can't just take the rate the state gives us, because as we'll see right here in the instructions, well, I'll just read them. This is the excerpt from the D-1 cost reporting instructions for these 19 and 20. It says, enter the average statewide rate per patient day paid under the state Medicaid plan for routine services furnished by nursing facilities other than certain NIFs listed here. Now, this rate is approximated. This is the unfortunate part, or one of them. This rate is approximated by taking the average rate from the prior calendar year, updated to approximate the current year rate. And then it says obtain the proper rate from your contractor, from us, the MAC. So even though at some point we will know the current year rate from the state, they're telling us we can never use that current year rate. We always have to use the prior year rate updated forward to the current year. And if you look at the regulation behind this, it actually uses the word trended forward, or the phrase trended forward, but it's the same thing as updated. And that update factor is based on the Medicare rate. That's the only place we can find an update factor, is back here. These Medicare rates, we basically figure out what update factor did Medicare use for that particular region. So for example, to get the 2024 update factor, we take 315.54 divided by 306.33, and whatever that update factor is, that becomes 24's update factor for region 1. I will say they're all fairly close, but they're not identical. The regions are all a little bit different, just by cents, basically, or by little tiny pieces of a percentage. So we get the update factor. Then we have to go to the state, each state that we deal with, which is 30-some that we have to, I think it's 35 that we have to deal with, WPS specifically, and we get their information. By the way, here's the list of regions. It's also on our website. So even though I said the CMS publishes the Medicare rate on their website, we also post it on ours as well. This link takes you to our YouTube video. It gives you an overview of all of this. It takes you to the Swingbed sniff rate link. That'll give you the same thing we just saw that a few screenshots ago. But all of that is easy until you get to the NIF portion. And the work behind that is quite a bit more in-depth. You can find it on our website, though, for each of the states that we deal with, once we get the information for that. Now, every year, every calendar year, we post it. So let me go back a bit. In fact, I'm going to open up a fresh version, so I'll show you the whole thing. Yeah, let's just do this. So it's out on our website. It's under cost report rates. So out of all the topics we have, it's cost report rates, swingbed rates. And then again, this is what we just saw there. Let me just go to this one first. This is the same stuff you see in the CMS policy manual. Again, 24 is the latest version. And then you get down here, we have all of the NIF rates. 24 is the latest one we could possibly have for the NIF rates, because we don't have the data to calculate a 25 update factor, and we won't until CMS publishes the 25 Medicare rate. So let's go to the 24 Medicaid swingbed NIF rates. We have this for every state that we service, where we have one or more providers in it. But notice some of them say pending. That means we're still working with the state to get the data for a variety of reasons that we'll talk about in a bit. There are delays for some states for various reasons. But at the top of each page, we try to give you an overview of when you might need this particular year's rate. We give you an example, for a 1231 cost report, here's where you would report this rate. And if it's already calendar year, then you don't need another rate. But if it's this year, you'll report it here. You'll report the last year's rate on line 19. So we go through the whole scenario. But this gives you the rate. This basically gives you the prior year calendar year rate updated forward to 2024. So for Alabama, for example, we would have worked with Alabama to figure out what their 2023 calendar year rate was. We would have applied the 24 update factor, and this is the result. Again, some of them are pending. we go through this, and I work with the states and get this data, and I update it as soon as I can. So, and again, you'll post it there. So back to the critical access hospital. They do not use the Medicare Swingbed sniff rate. And I guess, yeah, you cannot even post, it's not even open for entry for a critical access hospital, so you can't make that mistake. But you do need to post the Medicare or the Medicaid NIF rate. And this is important because this does actually carve out cost. This determines how much of the cost should not be used for the swing bed or the hospital. It's basically for your nursing facility, your Medicaid days, basically. So this rate needs to be reported here. And of course, at the time of our desk review or audit, we would make sure you've reported the proper one. Now, this is what I was alluding to a bit ago, that in some cases there are delays in getting some of the rates. One of the delays, of course, is that we can't, until we get the CMS swing bed rate, we can't calculate an update factor. Since CMS has only published 2024, we can't do a 2025 update factor because we need the 2025 CMS swing bed sniff rate. So even though we have some 2025, well, let me back up. We have some 2024 state data that we could have used to update to a 2025 NIF rate, but we need the 2025 update factor to do so. So as soon as CMS comes out with the 2025 CMS swing bed sniff rate, we can all of a sudden publish some of the 2025 NIF rates as well. Back to some state-specific issues, though. Some of the states are nice and easy. They already give us calendar year rates, and sometimes they'll give us prospective rates. They lock in their rates, and they say, these are the rates we pay. There are no adjustments, so they're nice and easy to use. We get the rate, and we can update it forward to the next year, no problem. Some of the states have so many different adjustments that they make throughout the year that they have to wait until the year's over and show us the retroactive payment rates that they actually did pay. So we have to wait till that year's over. That becomes even more time consuming or more of a delay when they use a state fiscal year that's other than the calendar year, because then we have to wait until the latest state fiscal year that touches part of that calendar year. We have to wait till that latest fiscal year is over before we can complete the calendar year that it touched. So as you can imagine, that could be a lengthy time period there. That's the worst scenario when they have retroactive rates, or I shouldn't say retroactive, that's the wrong word. They don't give us the data until after the period's over. They don't have the data until after the period's over. So in that situation, and when they also have a different fiscal year for the state, that's when it's going to be the longest delay. And then there are some states that just in general have a lengthy process to go through. We can't just email a contact and get the data. They make us go through loops through their, it's kind of like a FOIA type process for the state to get it. For whatever reason, they won't work with us very well. Then it takes more time. But the point is, if you're filing a cost report and you don't see the proper rate, the proper year out on our website, just use the most recently available rate for your cost report submission. And then when we do the desk review, we'll update it to the one that's available at that time. So that's what I wanted to boil down to there. So let's see, I'll check for any questions here. Okay, so that was swing bed rates. The next topic I wanted to cover is one we actually have covered in the past, and this is the RHC. It's been a while, and there have actually been a few changes since then. CMS has clarified a few things. This is another one of those things that was a little bit convoluted over the years. The instructions came out so quickly that I just don't think there was enough time for them to fully get everything published, I guess, in the right way. But let's go through just a quick background of the RHC payment. Historically, this was reimbursed on a cost per visit methodology known as the all-inclusive rate. So every visit that you had, there was a certain amount of cost reimbursement for it. Now, right here's the example of how that was, how it was apportioned out for that. You get a per diem, or I shouldn't say per diem, per visit, total cost divided by total visits throughout the year. And that per visit cost would be multiplied by just the Medicare number of visits, which would come from the PSNR. Now, there's one little piece in here that could come into play. This was the productivity standard, which I'm going to talk about again in just a second. The productivity standard basically said if you had a certain number of FTEs, every FTE has a certain number of visits that they were expected to have. And if they didn't, the visit count, the total visit count would be increased to that minimum floor. So, of course, if you increase the denominator of your fraction, your per visit amount is going to drop. So that if you're subject to the productivity standard, that's going to reduce your cost per visit, which obviously reduces your reimbursement. Now, I'm gonna take a little bit of a tangent here. I'm going to go off on just a little tangent for a second. There was a productivity standard exception, and certain providers that basically said there's a reason our FTEs couldn't hit that productivity standard. They could submit a request, submit justification, and get an exception from that productivity standard, and then you wouldn't be subject to that visit change. And there were a lot of good justifications that could apply. It was not a blanket approval across the board, but there could be some good justifications. The one thing I want to mention is that this whole productivity standard exception, well, the productivity standard in general is now gone. CMS removed that, and we'll see that in just a bit. It's a perspective, but we'll see that in just another slide here. I just wanted to show you as we're talking about it where that productivity standard is, but it's no longer effective for newer cost reporting periods. So your cost per visit would be multiplied by your Medicare visits to get your Medicare reimbursement for the RHC. Now, the other cap here is that you would be subject to a national per visit limit, which was updated annually. And M-3 is where all of this calculation takes place. You can see here we have the costs, the total visits to get a cost per visit, $919. And there's a limit for this facility. It was it's also for the different periods, $693 and $707, the calendar year limit. So of course they're well above the cap. So that cap is what would be used to reimburse them. That cap multiplied by the Medicare number of visits. So instead of getting $919 per visit for the 98 visits, that provider would get $693 for the 98 visits. So you can see that's quite a bit of a difference. Here's where that productivity standard kicks in. So the number of FTEs, the number of visits expected for those FTEs, and here's that productivity standard if they were exempt from it. Now, I talked about the cost per visit limit, but there historically was an exception for that for RHCs that were provider-based to a hospital that had fewer than 50 beds. There were some other ways to be exempted from that limit that were relatively rare, but the 50-bed exemption is the big one. So if you had that situation, you're exempt from that national limit, and in this case, they would have received the full $919 instead of about $700. That's a $200 swing approximately. Now let's move on. Here we're just setting the stage for the limit and the exception. That's all we're doing at this point. Now let's move on to the topic of consolidation. We're trying to talk about two separate pieces because we're bringing them all together in the last part of this RHC discussion. So consolidation of RHCs. The idea here is that there are many providers out there that have a lot of RHCs, a lot of rural health clinics to help support their goals, their initiatives of providing care to their rural patients. That's the idea. Each RHC that you have generally would have its own worksheet S-8 and M series. That's where all the data goes. The S8 is basically your control questions and everything that runs the RHC. The M series is the reimbursement type worksheets. And as you can imagine, if you had, 5, 10 or more RHCs, that's a lot of extra documentation. And CMS realized that, and they allowed facilities to elect consolidation as one large RHC for cost reporting purposes. The thing is, it doesn't impact your billing. You still have to submit the same claims because they are still individual provider numbers if you've set them up that way. But for cost reporting purposes, they can be merged together and consolidated as one. The requirement is pretty simple. You must elect consolidation in advance of the cost reporting period. And if you want to remove the consolidation, you can do that as well. You have to elect to do that also. This is where you'll find that, and it was recently updated for the issue that we'll talk about in just a bit. When I say recently, it's been a little while, but they did update it. That's the verbiage in red. This is found in CMS Pub 100-02, Chapter 13, and then Section 80.2. So this is where all the consolidation verbiage comes into play, and it talks about what groups can be consolidated. This is the piece that we need to hit on in just a bit here. The fact that they can be separate groups consolidating. It used to be that if you consolidated, all of your RHCs had to be consolidated. It was all or nothing. You could not have some consolidated and some not consolidated. You couldn't consolidate to a few groups. It was all or nothing. Now it can be consolidated into certain groups. Basically, it boils down to what type of base rate do they have and what type of base year do they have. That's what it boils down to. If there's going to be a different base rate or a different base year, then I shouldn't say base rate. If there's going to be a different limit or a different base year that led to a limit, then they need to consolidate into separate groups. So out of the 10 RHCs you might have, maybe they were split into 3 groups, a 4, a 3, and a 3, perhaps, depending on the situation. Line 88 of Worksheet A is where the hospital-based RHCs would be reported, and you can subscript it if you have more than one RHC or more than one group of RHCs. And this just talks about the whole, that's the consolidation there. S-8, so that's your control worksheet for the RHCs. Line 13 specifically asks you if it's consolidated cost report. And if so, then you need to enter the number of providers consolidated in that group and give the detail of what providers are consolidated with this group. So here's the thing I want to point out. Let me go back up here. For every subscript of Worksheet A that you have, basically every subscript, line 88 and or subscripts, that is an RHC and or a group of RHCs, a consolidated group. So every subscript you have needs to lead to a separate S-8. So for example, if you just had 10 separate RHCs reported separately, they're going to have 10 S-8s. If you had 3 consolidated groups, 3 separate consolidated groups, they're going to have 3 S-8s. If you had everything merged into one consolidated group, if you were able to do that, if everything aligned perfectly and you're able to do that, you would just need one S-8. And then each one, you would answer the question what providers go under this particular consolidated group. Every S-8 would also need its own M series. And this kind of tells you, that's basically what I said. This first line is what I said. M-1 is basically your worksheet A. It's your detailed cost breakdown of that line 88 or subscript. M-2 gives you all the visits and productivity standard, which again, for newer years is not applicable anymore. M-3 details the cost per visit calculation, which is certainly very applicable, even with the new rates that are in play, which we'll talk about here in just a second. Here's just a screen of M-1. It looks very similar to A, almost identical, only it's instead of actual cost centers, it's types of cost. It's breaking down types of RHC costs. Now we're on to where we're trying to wrap all these different discussions together. The CAA, the Consolidated Appropriations Act of 2021, which is linked right here, basically said instead of using these cost per visits, the regular cost per visit that was used before, CMS was setting new national RHC payment limits for visits. And they set them over an 8-year period. They predetermined these rates over an 8-year period so far. It's a national RHC payment limit. In 2021, they set the limit at a flat $100, and they inflated it forward for the next 8 years. So these are already locked in for anybody that is subject to these national RHC limits. Now, these are for RHCs beginning 4/1/2021. And let me back up. These rates are applicable beginning 4/1/2021. There's a disconnect in the periods that are listed here, and it makes it a little bit confusing. So I want to clarify that here. So those are the rates effective 4/1/2021 for payments. Now, the new rates, here's the disconnect. The new rates apply to all new RHCs that were established on or after 1/1/21. So again, if they were established on or after 1/1/21, then those rates start taking place for services on or after 4/1/21. But the other thing is they also apply to any facilities that weren't exempt, any facilities that were not exempt from the cap prior to 1/1/21. So if you were not associated with a hospital under 50 beds before 1/1/21, then now you're rolling up under this new rate. So obviously it would certainly have behooved a provider to be associated with that small hospital prior to 1/1/21. Now we bring in the grandfathered RHCs. These are the ones that were as of 12/31/20 in a hospital with less than 50 beds. Now there's a key phrase there. As of 12/31/20. And that exact day, we're not talking about a weighted average. We're not talking about a cost reporting period that ends 6/30/21, and then what's the average as of 6/31/21 or 6/30/21. We're talking as of 12/31/20. You're in a hospital with less than 50 beds. So I want to spend just a minute or two on that discussion because it is important. The bed count usually comes from E-Part A. It's the same. In fact, let me pull it here. Get my mouse back for a second. There we go. So go to E-Part A, and it's right here. E-Part A, we call it the bed count, but it's actually bed days available divided by the number of days in the cost reporting period. So it's line 4. And I don't have this on the screenshots or anything, but I'm going to pull this up because it is such an important piece to understand. If you look at S-3, what's happening here is you have a physical bed count as of the end of a period. The number of beds here in column 2 for each of your departments, That's your physical bed count at the end of the period. But the thing is, throughout the year, you might have increased or decreased the beds, brought some into service, pulled some out of service temporarily. So this is a snapshot as of whatever your year end is. The bed days available, if you made no changes whatsoever to your bed count throughout the year, to your physical bed count, this would simply be this number of beds multiplied by 365 days, or however many days were in your period. That's what would go right here. The thing is, if you added some beds or pulled some beds out, this number 3, column 3, would have to take that into consideration. So if for half the year you had 100 beds, and then for the other half of the year, I know this is a bit extreme, but for the other half of the year you had 150 beds, then this is going to be basically a weighted average. That's the easiest way to put it. This is a weighted average number of beds throughout the period. It's weighted based on the days that each of those beds were available. This bed days available is what basically comes over to E Part A. It's taking all these departments into consideration. It's adding certain things, subtracting certain things based on the DISH rules, the DISH, IME, all the other rules that apply, but that's what's coming over here. The biggest problem with this is that if your year end is 6/30, this by itself can't necessarily be used to prove that as of 12/31/20, you were in a hospital with less than 50 beds. So if you are trying to be grandfathered and you have to prove that as of 12/31/2020, you were in a hospital with less than 50 beds, then you actually have to prove that, let's say you start, if you've had less than 50 beds all along, no problem. But if you had 100 beds or 80 beds, and all of a sudden you're trying to prove that you got down below 50 beds in time for the 12/31/20, you need to prove that you decertified those beds or pulled them out of service, where they could not be put back into service within 24 hours by the 12/31/20 timeframe to meet this grandfathered status. That's the point. It's not enough on your 6/30/20 or 6/30/21 cost report to show that, hey, this is below 50 now. That's not enough. That proves as of 6/30/21 you're below 50 beds, but that does not prove that as of 12/31/20 you were. So that's the point I wanted to make there to get this grandfathered RHC status. So if you're in that situation, we would be requesting documentation to show how you pulled those beds out of service and how they could not be used for patient service as of 12/31/20. The beds could have been, the rooms could have been converted into other use. You could have disconnected the gas hookups. You could have decertified the beds completely, delicensed the beds. We would just need to show how those were fully pulled out of service so that you're below the 50 count. So that's what I wanted to point out there. And let's see. Oh, the other thing, of course, is you must remain less than 50 beds. Otherwise, you lose that grandfathered status. It's not a one-time thing. It's not, hey, I'm below 50 beds as of 12/31/20, and then all of a sudden, the next year, you're above 50 beds. You have to continue to be below 50 beds. Otherwise, you get moved over to the national rates. And at that point, you're gone permanently. You'll never be able to get back into your cost per visit status. Now, the good news, though, one of the things that CMS did directly address was that if you have a change in an address or a change in an ownership, that's not going to cause you to lose your grandfathered status, that in and of itself, as long as the hospital with that provider number was less than 50 beds. Yeah, it could change ownership as long as they didn't change the provider number. As long as they accepted the provider agreement and the provider number, they'll still be fine. Here's the reference to where that can be found explicitly. And we talked about the payment limit for the grandfathered RHCs for 2021. So as an example, that's going to be the greater of the calendar year 2020 base year cost per visit multiplied by the calendar year 2021 update factor, or just, of course, the national RHC cost per visit, the $100. They're never going to hurt you by being grandfathered. It's never going to hurt you. They're never going to put you below the national limit. You're only going to get equal to or above that national limit. 2022, it's the greater of that 2021 base year cost multiplied by the update factor, or again, if the national limit's higher, then you'll get that. And yeah, here's a little blurb. If you didn't have any costs in 2020, then of course the next year would have to be your base year. 2021 would become the base year because we couldn't calculate a cost base for 2020. And yeah, so you even though you didn't have to have costs in 2020, you must have at least existed by 12/31/20. You might not have provided any services yet to incur costs, but you had to have existed. And CMS does mention that in the Federal Register. If you existed by 12/31/20, you got that locked in to be grandfathered, and then you start providing services sometime in 2021, then you can be good to go. And if you stay below the 50 beds, of course, for the hospital. So now we're to the point where we're mixing both pieces together. We've got the consolidation, we've got the whole new base years. The consolidation, now that we know that there might be some RHCs that are subject to the new rates, the federal rates, some are grandfathered. So the question is, and just by the year, obviously they're either all with the hospital under 50 beds or none of them are, because it's obviously the exact same hospital in question. So that's not the point. The point is, when were they established? Have they been around for years, or are they newly established? That's the issue at hand here. That determines whether or not they might be two separate consolidated groups, the new versus the old. If they're, of course, if they're above 50 beds, then it's a moot point because none of them are going to be grandfathered. But if they're under 50 beds, that's where this issue comes up. Some might be grandfathered, but the newer ones won't. And that's where we might have two separate consolidated groups. The finalized rule does clearly allow this. We might even have more than two separate consolidated groups, because what it boils down to is you need to determine how is that base rate going to be established. And the other thing is, some of those RHCs, if they're not even grandfathered, if they're all under the federal rate, any of those federal rates can be consolidated together with no problem. But then for the ones that are grandfathered, well, what rate are they going to be using for their base rate? If some of them used a 2021 year, some of them used a 20 year, they would have to have their own consolidated group. So you might end up with three different groups of consolidated units there. And that's basically what this boils down to. Here, I just threw out an example where we had two groups, but you could have potentially three. So we had to go back and forth with CMS on this quite a bit. And basically they admitted that yes, you can have more than one group, and it all boils down to what rate are they going to be using. They have to have the same rate developed, basically. And let's see. All of that just comes from we're talking about, this is the reasoning behind that. We cannot recalculate the base rate. They can only be consolidated with those of the same year. That's what it boils down to. And here we have our different groups. Here's what I was mentioning earlier. The RHC productivity standard is discontinued, effective for cost support fiscal year ending on or after 1/1/25. Now, the reason CMS did this, they basically said, hey, with all these new rate rules that are in place, that is sufficient enough to control the cost. So there's no reason anymore to try to control it further with these productivity standards. That was basically their explanation in the Federal Register. So that's helpful. You're not going to be controlled from two different angles anymore. They're doing all the cost control through the new rates. So there's no productivity standard, and obviously that means there's no need for a productivity standard exception for these newer years. But of course, we're still handling productivity standard exceptions for the older years, no problem there. Okay, so now we are moving on to our last topic. Let me make sure if there are any other questions. Okay, so the last topic we have here, the last big one before we do the wrap up, is related to the CRNA, the Certified Registered Nurse Anesthetist, and really the broader term for this is non-physician anesthetist, the NPA. That's actually what the label on the cost report relates to. CRNA is just one type of them. It's by far the most common type. But this pass-through payment methodology is found in 42 CFR 412.113C. Now, the qualifications for this are that they have to be in a rural area, and the hospital or CAW, because it can apply to an acute or critical access hospital, must have employed or contracted with a qualified non-physician anesthetist as of January 1st, 1988. That's a key thing. There has not been any sort of rebase is the wrong word, but there's not been any sort of restart of this to bring it up to a new year. So if you did not exist as of 1988, first of all, you will never be able to qualify for CRNA pass-through. But let's say you did exist as of January 1st, 1988 as a hospital, you would need to prove that you employed or contracted with some non-physician anesthetist. Again, employed or contracted. So there needs to be proof of that. That's the first thing. Now, once you've proven that, then of course you're good for the remaining years as long as you meet all these other requirements. The next one that you'll meet each year is the procedure count. Now, there are two pieces to this as well. There's the base year count, which if you can't meet this, again, it's a base year, so if you can't meet it, you're done permanently, unless CMS decides to restart this or rebase it, if you will. But this base year, it's actually the prior year to the base year. The base year up here, again, we said 1988 was kind of the base year they're talking about. So procedure count is always a prior year type thing. So we're looking at current or calendar year 1987, which is the prior year to 1988. That's where this is coming from. So the number of surgical procedures requiring anesthesiology could not have exceeded 800. 800 is the new threshold. This has changed over time. It's 800 now. So if you can prove that your number of surgical procedures did not exceed 800, okay, you've met this one. If you cannot prove this, if you know they were over 800, then you're kind of dead in the water unless CMS updates this from 800 to maybe 1,000 or something down the road. They've updated it 3 times over the years. But the year itself has remained the same. It's just the number that's changed. So you meet this, and then every single year you have to prove that the prior year to your current year also did not exceed 800 procedures. Surgical procedures requiring anesthesiology. So procedure count there. This gets submitted every year. Oh, and by the way, even though we're talking about a calendar year, there's also a clause in this regulation that says something like for administrative efficiency, they're actually using 9 months, basically January through September 30th. They're using that, and then they're annualizing it to a full year, because keep in mind, this has to be approved by January 1st. It has to be sent in before then, so it would make no sense to try to use all the way through December 31st. So you submit data from January 1st through September 30th when you submit your request, and then they annualize it to approximate a full year to prove this 800 procedure count. So that has to be submitted. And then the other thing that's done based on the current year, and it's generally done during desk review, depending on the scope, you have to be able to show that for the CRNAs you had, the anesthetists, just generally, no matter how many you had, you could have a few part-timers, you could have one full-timer, but there could be no more than 80 hours of service, basically one FTE. Now, this is any service. So the procedure count is based on just surgical procedures requiring CRNA or requiring anesthesiology. This is any services performed by this CRNA, by this anesthetist. So they cannot have more than 80 hours of service. Otherwise, the whole thing's out the window for that year. So just as a summary, there are a couple of things that if you don't meet, then you're kind of, it's permanently tainting your ability to ever qualify for CRNA. This thing right here, if you did not exist or did not contract with a CRNA in 1988, or I shouldn't say CRNA, well, a non-physician anesthetist. If you didn't contract with them in 1988, it's permanently tainted. If you did not meet the base year, it's permanently tainted. But these other two things are a year-by-year type of thing. If you don't meet it this year, well, maybe you'll meet it next year. So that's the qualification. The benefits. Again, we're talking both acute care, IPPS, and critical access hospitals. For the inpatient side of things, you get pass-through cost reimbursement in lieu of fee schedule. Now, most of the times that's more beneficial, but I don't know that I'd say all the time. That would be dependent on your individual situation, but I would probably say the vast majority of times that's going to be beneficial. Now, for outpatient, though, this is important to understand. We just recently came across a situation like this. After 4/1 of 2004, this is not cost reimbursed pass-through for an IPPS hospital on the outpatient side. After 4/1/2004, the quote-unquote pass-through is actually an APC bundled payment in lieu of fee schedule. So on worksheet D part 5, and I'm going to bring this up just to make this point for any provider that might have this issue. But I guess before I get there, the point is that you should not be receiving cost reimbursed CRNA on the outpatient side if you're an IPPS hospital. And the instructions are fairly clear about it. But if we go here, this is just a generic D part 5. So we have a couple of different places where you would normally report your outpatient PS&R Medicare charges. Any of the PPS reports, the ones ending in P, 12P, 13P, 14P, those go in column 2. That's where they just need to go. And these are PPS reimbursed services. That basically means there's not going to be any cost reimbursement for them. And here you might have your anesthesiology. That's generally where you would put your CRNA charges. You might have some of them going elsewhere, but that's generally where they would go. Your 12P, 13P, 14P, they need to go here. Only the 120, 130, 140 reports would go into these, and only potentially, well, they go into these. So it's only these other columns that generate cost reimbursement, as you can see by the label, cost reimbursements, cost reimbursed services. And there should generally be relatively few of them for an acute care hospital. Most of your charges go into PPS reimbursed. The situation we saw recently, a provider was trying to report their, I think it was 13P CRNA charges here because they were thinking, well, hey, we need cost reimbursement. We have a pass-through. And they knew on the inpatient side, they got cost reimbursement. So they thought on the outpatient side, they're supposed to as well. And they realized that this is the only way to get cost reimbursement on D Part 5 for an acute care hospital. The thing is, they're not supposed to get cost reimbursement for an IPPS hospital on the outpatient side. You're not supposed to do it. In fact, if you go to because it's paid with that bundled APC payment. If you go to D Part 4, which is where the pass-through is actually kind of being calculated, and I want to specify that pass-through cost reimbursement is not the exact same as straight cost reimbursement. Even on the inpatient side, it's a slightly different payment, and it's basically due to the different cost to charge ratios without going into great detail. So we have on the outpatient side, if this were to be a pass-through payment, you'd have your non-physician anesthetist cost. Now on the inpatient side, it works. Your non-physician anesthetist cost, and it goes through and it develops an inpatient cost to charge ratio, and it gets multiplied by your inpatient charges. So that would be where your PSNR charges for the inpatient side came through, and it tells you what your inpatient reimbursement is going to be. But the outpatient side on D Part 4 does not work that way. In fact, I'll tell you right here's where it is. Total outpatient costs. Well, let me look at total costs first. This is what's used to determine the inpatient cost to charge ratio for the pass-through. It adds columns 1, 2, 3, and 4. CRNA, nursing school, allied health, and any other medical education. The total is what's used for inpatient. Here is total outpatient. This is what's used to calculate the pass-through outpatient cost to charge ratio. Notice it excludes column 1. It excludes CRNA intentionally, because CRNA on the outpatient side is not supposed to be paid pass-through cost reimbursement. So just to stress one last time before I go through the rest of this, CRNA for inpatient PPS hospitals, let me back up. CRNA for acute care hospitals on D Part 5 should not be paid cost. They should not be reported on columns 3 and 4 at all. Those charges need to be under column 2 because they do not get paid cost reimbursement. They are getting paid an APC bundled payment in lieu of fee schedule. That's their pass-through, so to speak. So because this could potentially be a big issue, I'm going to be putting an update to our website. It's obviously not something new, but it's something we've just seen. One example, I hope there's not any more examples of, but I just want to make sure it's clear to everybody. So I'm going to be updating our website with information on that. From the cost side of things, however, both inpatient and outpatient can get cost reimbursement in lieu of fee schedule. And that could very well be beneficial. In fact, it's 101% cost reimbursement for a CAW. On the outpatient side, they actually have another option. If they're a Method 2 provider, they can give up the normal cost reimbursement exemption to get paid this Method 2 115% fee schedule payment in lieu of their standard fee schedule. So don't need to go through too much detail there. For these last few slides, these are more just kind of informational, showing the revenue codes, the PSNR report types, some of which I've already gone through. But this basically breaks out for your CRNAs, you're going to have two components. You're going to have your technical or facility component, which is just going to be reported like normal, whether you have a pass-through exemption or not. This is not what's being reported as cost reimbursement. It's the professional component we're talking about, the pass-through for. So professional component is reported under revenue code 964. And that's, again, for the outpatient, it's going to be reported under 12P, 13P, or 14P for an acute, 850 for a CAW. And then generally you're going to see that under line 53 for anesthesiology, but you could have it elsewhere also. And I already went through the D Part 4 discussion that I was going to talk about. So that takes us through that topic, and the last couple slides here that you can use for informational purposes. I just have a link to our WPS website, our YouTube audit playlist, which is where we will put our provider webinar recording. And then here, I narrowed this down to just our most recent YouTube videos that we've put out there. I will say this last year, one of my main focuses has been on the SSI projects in the reopenings area. So I haven't had, other than our webinars, I haven't had really a whole lot. I think I had the RHCs at the end of 2024, organ acquisition, but I didn't really have much else. The beginning of 2025, we were wrapping up the SSIs, but I do have some plans for some additional webinars, some additional YouTube videos. Here are some topics that are on the training list for that. Certainly, if anybody has any ideas they'd like to see, feel free to send those on. And with that, we're right at the noon hour. Let me see here. I wanted to post the survey link one more time if you have a chance to. Oops, it says it's failed. I guess it won't let me post it. Yeah, it's not going to let me post it again. But if you go to the beginning of the chat, you'll see that again. I'm not sure why it's failing there. But if you have a chance, just a minute or two to take that, I'd certainly appreciate that. We love any of the feedback you can give us so we can improve on our sessions. But again, thank you very much for taking the time to join us for our session today. And I will be sending out an email. It'll be after the session tomorrow. I'll send the first email with just all the information, the YouTube recording, the handouts and everything. And then there will be a follow-up email with the actual certificates and all of that. So thanks again for your time. I hope everybody has a great week, and I will talk to you in our next session. Have a good one.